Okay, and I'll share my screen. So hey everybody, thank you so much for coming to our third general body meeting. We're really happy to see you all here, and we hope that you get to learn a lot from today's meeting, especially with Dr. Fontana coming. And yeah, I'll lead it to Adam so he could explain the agenda of the day. Yes.
Hello everyone, we're so delighted to have you here today. Before we're joined by Dr. Fontana, we will have a brief overview of programs and events coming up. And first, we'll be discussing our pre-health mentorship program, and I'll hand it off to Victoria and Ishan to tell you more.
Can everybody hear me well? Yeah. Hi, how are you guys? So me and Ishan are very excited about the mentorship program that we've started here at AMPC, and we just want to remind everyone that the program application interest form is due tomorrow night at 11:59 p.m. And we're just going to give a brief overview about the program, and you should find the links in the chat. Okay, so we're so excited about our new program, and we want to share with you some of the main things about our program and what we hope you all will get out of it. Our focus is to provide an outlet for a more personal connection between the underclassmen and upperclassmen members of AMPC. And we really want AMPC to just feel like a community where we're more than just like colleagues and we're all friends with one another. And we believe that this program is going to be just like an awesome opportunity for underclassmen to receive guidance through the difficult yet rewarding journey of becoming a healthcare professional. And right now we're working on pairing up mentors and mentees based on your interest form responses. And next, Ishan is going to explain some of the main goals of this amazing new program.
Thanks, Victoria. Yeah, let's talk about some program goals. So, especially for freshmen and sophomores, you might, and since we're online, finding good mentors is going to be very difficult, and that's what AMPC is here to remedy. Finding a good mentor is literally the key to getting everything. And today's education, getting good grades is enough. You need to be able to get your research. You need to get all these different things. You get volunteering, and through that, mentorship is the key. With a good mentor, you can access tons of new opportunities. Like doors will open that you didn't even know existed. I know from personal experience, my mentor showed me like 3 new research opportunities that I would never have even looked at because it's not something you can find online. So I can't stress enough how important it is to do that. And yeah, when you make those strong connections, they multiply. So I'm speaking for personal experience, but I know this program can work for you guys too. And I'm so excited to see what I can do. So yeah, let's talk about the timeline a little bit. Thank you guys so much for applying and sending in your applications. We have, I want to say 42 participants so far. And after this GBM, I hope to make it a little bit more because we really do hope to make AMPC feel more like a family instead of loosely bound individuals. So the next step we're doing is after the deadline tonight, Victoria, me, and the entire e-board will be working really hard to assemble you guys with the best mentor-mentee pairings. And the way we have it so far is that we have a lot of mentees and we're having like a 1-to-4 mentor to mentee ratio. So you're really going to have mentee groups and you're going to have, I think that's a great opportunity because you get to interact with not only your mentor, but people that are on the same level as you. And that's just more connections, honestly, like going back to the same point. To give you guys a rough timeline, I would say that you should expect these groups to be formed in the next 2 or 3 weeks. And we will be sending out emails as much as possible, keeping you guys informed. And yeah, I'm looking really forward to it. It's a great program. Make sure to sign up by tonight. Thank you, guys.
Okay, so we're very much extremely excited to introduce you guys to our health and wellness program. The purpose of this program is to enrich our knowledge of anxiety and depression amongst the pre-health community. while also being able to help one another and share everything that we've been feeling lately, whether it is related to school or life in general, our future aspirations, fears, COVID-19, or literally anything. So this is a 2-week program that will start on October 25th and it will go until November 6th. Okay, so this is the program calendar that we have for now. Some of the dates of activities and times might change, but we will update you all if this happens. So we will send you a form of interest so that you could let us know which events you will be able to join and which ones you're interested in. And then just to quickly go over the calendar, we will begin the program on Sunday, October 25th, as I said, with a group discussion, which just entails us talking together about any topic, issues, news, overcomings, or anything that you would like to talk to us about. On Monday, we'll have a quick yoga session, which is kind of weird, and online. But that's to de-stress a little bit and get ready for the week, since that most of us have lots of exams or other things coming up.
Yeah.
We can hear someone. Okay. On Wednesday, we have what is
Where do I
called.
have to send it to or put it on?
Wait, let me put. Okay, I think that someone is talking, but whatever. On Wednesday, we will have what is called the CMMP Rounds Initiative with our partnership with Howard University, in which I'll let Adam talk to us about more. And then on Wednesday, we have our meditation YouTube video day. I found it online and it's only 10 minutes long, but we can also chat a little bit about anything that we've been feeling lately. On Friday, we will have a therapist or a psychologist coming to talk to us about COVID and anxiety, but we still have to confirm their availability. So if it changes, we'll definitely let you know. On Saturday, we have a group discussion again for those who want to open up or couldn't come on Sunday, or for those who just want to chat and even stay longer and study together. So then on the next Sunday, we have Dr. Friedemann coming. He's a dermatologist that will be talking to us about the effects of anxiety and depression on the skin. In case that he can't make it, we will try to have psychiatrists come, but as I said, we will let you know. Then on Monday, the 2nd, we also have a group discussion session, which shouldn't last for more than an hour. On Wednesday, we have a 15-minute long meditation session again, just to relax a bit and enjoy the present moment. I don't do yoga or meditation much, but we'll try. And then on the last day, which is Friday, we have Dr. Steinau, a psychiatrist that some of you may have already met, come and talk to us. And just to let you know, those topics of the day that is written is mostly for Instagram purposes, but we can definitely also talk about these topics during the events. So now I'll ask Adam to talk to you about the other upcoming events of the month.
Hey, can everyone hear me? Okay. Yeah. Hey everyone, this month is very exciting and filled with wonderful events and interactive activities. We recently received some educational medical kits that we'll be utilizing to make educational short videos and to help you get a head start in preparing for your clinical experiences down the road. So let's do a deep dive into the calendar. Today, we're joined by Wall Street Journal featured neurosurgeon, Dr. Elizabeth Fontana. Then this Wednesday, we will be joined by Dr. Chavez Valdez, a neonatologist and associate professor of pediatrics, doing groundbreaking work at Johns Hopkins University. Usually, we host our academic activities on Fridays, but due to time conflicts with Dr. Chavez Valdez, we have scheduled this for this coming Wednesday. On Friday the 16th, we will be joined by Dr. Willie, a professor at Hofstra Medical School. She is the chair of the Department of Science Education. She is also very active in the admissions program for their medical program. She also directs the MS-MD program and is very familiar with the many different programs and paths towards a career in medicine and can be very helpful to you and our other members. We will be hosting office hours every Friday and Saturday, as usual, where we do deep dives into opportunities for research, volunteering, clinicals, and shadowing, as well as providing advice from experienced upperclassmen like me and Natalia, who have gone through what many of you have already done, have ahead of yourselves. And then in 2 Sundays, we will be joined by Dr. Piasotto, a nephrologist at Yale Medical School. He's a professor and works in the residency program, so he has great insight into what makes a medical student stand out for a residency application. Then we'll be joined by Dr. Semnow, who will be having a workshop with us and bringing in a former patient or doing a directed patient-related activity with us to get you guys some more clinical experience. Then on October 28th, on a Wednesday, we will be working with Howard University in the CMMP Rounds Initiative, which is essentially a virtual clinical experience where you are guided from beginning to end of an emergency medical situation, where doctors will walk you through and have you decide what steps will be taken to treat a patient. So that's our very, very exciting, and will be happening on a Wednesday instead of our usual Fridays and Sundays. Then on October 30th, we will be joined by Dr. Diamond, who is a urologist in the New York City area, and we'll be discussing what it takes to stand out for a urology residency, as well as discuss the life and career of a urologist. And now I'll hand it back to Natalia to talk more about AMPC Symposium.
So as most of you know, we are offering a symposium this and next semester. So our goal is to help pre-health students be involved in research with different professors and hopefully getting published next year. We have been contacting some researchers, and we added 4 new professors to our list last week. So they're mainly related to research that is related to radiology, LGBTQ and public health, dentistry, health politics and management, global health, and attention. So once we have all of them, we will send you a form with topics for you to choose your preferences. And I believe that we will also send out an email this week to have a list of members that are interested in being involved in our symposium, and also getting your email so that we can maybe all meet and discuss a little bit more about it and answer your questions. So although we will have some researchers working in wet labs, we do think that when we send out the form with topics, most of us, you and us, should choose at least one dry lab or public health related research, because we fear that we might not be in person next semester. Hopefully we are. But then conducting a wet lab online and also getting published is a lot harder than being involved in a dry lab. So hopefully this changes and we'll be in person, but we will continue to update all of you and answer any questions that you might have. Oh, you're muted, Adam.
My bad. Right, so does anybody have any questions or concerns that they would like to go over before I continue? Anybody? You can put it in the chat room as well if you don't feel comfortable saying it. Okay, seeing as there are no questions, we'll just begin. So before Dr. Elizabeth Fontana joins us, we would like to do a breakout room so we can get like a more intimate experience and just talk with our members more and discuss with you guys research opportunities and how to get them here at GW. It can be a daunting process, and we know that from our own experience, we have some insights into how to get situated and find research labs here at GW. So, Natalia, oh, there is a question. Where would we be publishing science journals, medical journals?
Would you like?
Yeah, so we would. Oh, okay. So yeah, right now we've been doing our research and finding different medical journals. There are many journals that we found. One with UCLA. We even had one reach out to us about it, and so we would be publishing in scientific medical journals. It wouldn't be just just quote unquote just publishing. So this would be this is what we're organizing this now.
Okay, I'm organizing the breakout rooms. If anyone has any question, feel free to shout it out or type it in as well. It could be related to anything, honestly.
Sounds good.
Sorry it takes so much time to divide people into breakout rooms. Um, I'm so sorry, guys.
Where will
Okay, I think, oh, we're good now. Yeah, because I have to like reassign everyone and put at least one of the e-board members in each. And so it takes a little bit of my time, but
I think Omar has a question.
oh,
We have like 8 minutes left, but this isn't something, the predatory drones, I'll just be honest, we're still looking into that. We haven't figured that out completely yet. But yeah.
okay, I guess I'll do it now.
Okay.
Hey guys. Oh, Presley, you're here too.
Okay.
Okay, I guess everybody is back from the breakout room sessions. I know that was really quick, but I hope that you got to interact a little bit. And now I'll present you guys to Dr. Elizabeth Fontana. She's a neurosurgery specialist in several hospitals affiliations, including Lennoxville, which is the same as Dr. Langer, as we had him a month ago, I believe. And she's focused and dedicated to providing service of tremendous quality and lots of compassion to all of her patients. Yeah, so the floor is all yours.
Okay, cool. So I guess I was just going to start with the some background because you guys sent me quite a few questions, and it'll probably take a long time, honestly, just to plow through all of them. So I figured, and then I have a case which we can go through at some point. why don't I start, and then we'll see how the timing is and go from there. So I am originally from Boston, Massachusetts. I went to public high school, and then I went to college at Harvard, and then I took actually almost 2 years off. It wasn't all sequential. One of those years I kind of did, well, I took a semester off, which set me off schedule. So I took a semester off, like the first semester actually of my senior year, I guess it was. And I just was burnt out actually. And I just kind of like taught, I was a TA for chemistry. I played a lot of piano, did a ton of music. That was what I did that semester. And I wasn't really sure what I was going to do. I had originally come in as a pre-med, and then I had decided I maybe wanted to go into research in chemistry. And then I was just kind of feeling like I didn't know. So that was, you know, it was a good thing to take some time off and sort that out. So I decided I wanted to go to medical school after all. I then came back, I took my MCAT, finished up my senior year in the winter, I guess, of the following year. And then I had essentially a year and a half to fill. And I worked in research at Brigham and Women's in the medicine department, doing like hospitalist research. And that was great. It was fairly flexible. I got to finally really spend a lot of time in the hospital, which I hadn't really done. I'd always been in a lab, and I enjoyed, it was interactive because it was clinical research. I was working with the patients primarily, which was also like very positive experience and kind of reinforced my plan to go to medical school. I also happened to work for somebody who was fairly flexible and allowed me to do a fair amount of shadowing of other subspecialties. So I got a chance to really get a flavor for some of the other things in medicine. And that was quite valuable, I think, because, you know, I was able to go into medical school with some semblance of things that, you know, an idea of what might interest me. So anyway, I then went to Columbia for medical school. I came to New York, and I stayed for residency. I didn't take any time off between medical school and residency because by then I had taken 2 years off and I didn't want to take any more time off. And then, you know, when I came into medical school, I had an idea that maybe I was interested in neurosurgery because I had shadowed some neurosurgeons. But I wasn't really sure, and a lot of people kept telling me that was a really bad idea. So I tried to convince myself to do pediatrics, failed, and I ended up doing neurosurgery. And then I stayed for residency, which is a 7-year program. All of them are, although there were some, I think, 6-year programs at the time. But anyway, mine was 7, and that's 5 clinical years and 2 research years spread out. Then I did a year of fellowship in Seattle, and I came back because I was by then totally smitten with New York City. I'd lived there for, you know, I guess 11 years at that point, and I really wanted to come back. Also definitely realized I was a Northeasterner and not a West Coast person. So got a job with Northwell. And I have originally, when I came in to the department, I was actually covering primarily the county hospital out in Long Island, which was very interesting. It was like a safety net hospital, not insured patients. And it was a bit rough and tumble, very different from anything I'd experienced before. And then, and now I'm at the regular hospitals. So I cover 3. Lenox Hill is one of them, and then there's 2 others that are out on Long Island, North Shore University Hospital and also Long Island Jewish Hospital. So busy. So the path to going to neurosurgery can be a little bit circuitous, as can any path. It is traditionally 4 years of college, 4 years of medical school, 7 years of residency training, and typically a fellowship after that is 1 year. Some of them are 2 years, kind of depends on what you're interested in doing, but the vast majority are 1 year. I would say about 50% of trainees end up going into private practice, and then the other half go into academia. If you go into private practice, you may or may not decide you want to pursue a fellowship. If you go into academia, you're more likely to need to go to pursue a fellowship just for job marketing purposes. Did I ever consider another field? Yeah, I did. Like I said, I really was trying to convince myself to do something that was a little bit more lifestyle friendly, which neurosurgery definitely is not. But you also have to do what you love. And I mean, I love my job, but it is not the same as my life would be if I was a radiologist. And so that's the answer to that question. So then setbacks applying to medical school. I guess applying to medical school was easier when I was applying 20 years ago than it is now. I mean, I just have seen a few kids pass through the application process in the last year or two, and it is so brutal. I mean, so is the college application process for that matter. It's just gotten so much more competitive. So I think, in applying to medical school, you just have to do everything you can to set yourself apart, but you also have to have the grades. Like the numbers just have to be there because you're competing with so many people who have like perfect scores. So if you don't, it's like already automatically like like a strike against you. And then I think, and I've seen a number of people who are just like such, they're going to be great doctors, and like if the numbers just don't support it, it becomes like such an unfortunate obstacle. So for those of you in particular who are early in your path in college, I think it's important to realize that of all the things that the admissions officers are looking at, that's for sure one of them. And they may or may not tell you that, but it is kind of true. And then, of course, all the other stuff. So research is always great. If you have publications, it's impressive. And then just things that make you, that make you likely to be a good doctor. If you have a good story, if you have a good essay, if you have good letters of recommendation, if you've done something extraordinary that's humanitarian in some way, like, various service projects, I think are valuable. I think that it's a good for you more than it's good for anything else too. I think in particular the service stuff helps you figure out what you like doing, and that's maybe more valuable than anything else, is just to know what really like makes you happy and makes you feel connected to what you're doing. So I don't know that I can really answer your question about, what my experience was applying to medical school relative to yours. I mean, I can say I did research. I didn't actually do that much research in medical school. I did it during the summer, and I had done a fair amount before I applied. And that was probably the vast majority of my, I had some publications from that. So if you haven't got any research experience, I think in particular for neurosurgery, like it's a useful thing because you're going to have to do it at some point. But for the purposes of applying to medical school, I think it's just a question of how valuable the research is going to be. I wouldn't do something just to check the box, but if you think you're going to get something useful out of it, then it's certainly a good idea. It'll look good on your resume. And anything that's clinically oriented is going to be informative to you too, just to get you in there in a sort of a hospital type setting. Failures along the way. Everyone has lots of failures. It's just part of life. You know, I mean, I've had too many failures to count. Like, you know, but successes too. So it's like, what do you count as a failure? You know, not getting into the school of your choice, or not getting, I don't know. There's just like so many things that that have transpired. But so you'll have to be a little bit, maybe you guys can ask me some specific questions about if there's something you're thinking of, but I mean, it's just, you know, you don't do well on something, or you don't get a good score on your rotation, or you don't get a good score on your grade, or, I mean, this stuff is just life. And, or your boyfriend dumps you, or, you know, I mean, and then things get harder as, you know, you don't get the job you want, or you don't get the fellowship you want, or, you know, the stakes, I do think they often get higher as you get older. But you also get better at dealing with setbacks as you get older. So, you know, I don't know. I think everyone has their own coping mechanisms for it. I do think it's very useful in general to have something that you like, some kind of outlet, whether it's running, or whether it's some form of exercise, or whether it's some sort of creative art. But whatever it is that works for you, I do think like it's a good thing to have in life, to have something that you can kind of like turn to for solace when, particularly in this day and age, when you can't necessarily turn to people. So that's all I have to say about that. And then my work-life balance, it's, I mean, it's pretty out of balance. So I'm a single mom. I have 2 daughters. One is 6 years old and the other is almost 2. The oldest daughter is adopted. The second child was actually with a donor. And the, you know, the chaos is just like total chaos in my house, like all the time. I also have 2 small dogs which preceded, I'll just say they preceded the children. So, and then we have like it now with COVID, like a variety of wildlife that has like descended upon like the New York housing. Like pigeons, you know, every once in a while we have like, you know, anyway, it's like a, it's been different. So yeah, you know, I spend a lot of, I spend all my free time with my children, and you know, they go to bed early, so that gives me some time to socialize and do other things. But you know, I take a lot of call. I work on the weekends quite a, you know, fairly often, and I get woken up a lot at night by children and dogs and phone and the hospital. So, you know, it's just, you do get used to it. I think, you know, the training for neurosurgery is, it's so rigorous, and you get so accustomed to certain amount of pressure and chaos and disruption that it's not such a difficult transition to living your life that way. But not everyone wants to live their life that way. So, you know, neurosurgery is not particularly conducive to having a balance in terms of your work and home life. You know, as people get older and more advanced in their careers, you have a lot more control over your schedule. That's true of virtually any career choice. And so and it's true for neurosurgery too, but that time frame is quite late. You know, I mean, like if you guys go into business school when you graduate from college, you know, you're going to have relatively little debt, and you will start your career, you know, in your 20s. And then you'll have all that time that you've been sort of progressing. Whereas like in neurosurgery, you don't actually become a real like functioning attending until you're like 35 years old, 34, 35, somewhere in that ballpark. So that's quite old to like suddenly like be let loose on the world and like, you know, be able to finally afford to buy your own car and all these kinds of things that like all your friends did a decade ago. So, you know, you are a little behind the 8 ball in terms of like life in general in some ways. And that just translates to you being older when you're sort of quote unquote senior, I guess, in your field. So, you know, what might look like a 40-year-old, you know, attorney's seniority is more like a 55-year-old for a neurosurgeon. But I mean, it's very fun. I don't ever get bored with my job. And it's just like perpetually changing. You know, we see different you know, different problem every day. So even though you see, like, for example, like no two brain tumors are alike. I mean, there's lots of similarities, obviously, but like, you know, and the same is true for everything. Every body is different. And so you get a different experience every time you do surgery. And it's also just a really fun activity. It's like you're doing something and it's helping people and it's fun and you get to, you know, I don't know, sort of feel challenged at the same time as you're doing this thing where you're really focused and you are in this space that's very well controlled. So in that sense, it's almost like doing a game or a sport or something where you're like in this like moment where it's just you and this task, and there's no like distractions of any sort. I mean, there are sometimes, but you know, you get pretty good at like tuning those things out. And so it's just, I don't know, there's something really, really rewarding about the act of operating. And I think that most neurosurgeons love operating. I don't know about other surgeons. I can't speak for the other specialties, surgical specialties, but I can tell you, I don't know very many neurosurgeons that don't really love to operate. It's really fun. Which challenges? I would say there's a couple of challenges, and then there's a couple of things that are particularly difficult about neurosurgery. The technical aspect, I would say, is not so much. You know, the hard thing about neurosurgery in general is making judgment calls and making decisions. And that's really what the training is so long for, is learning how to solve the problem in the safest way possible. And so that's a challenge. It's always a challenge. You know, you're telling somebody that they should do this thing, and they are trusting that you are making the best decision or offering up the best solution possible for them. And always that there's a risk that they'll have some severe potential sequelae from that, because neurosurgery has complications. So there is a lot of responsibility in that thought process and that discussion, and that's particularly challenging every time. Doesn't matter how straightforward the surgery is. The second thing I would say that's like the daily challenge. The second thing that's particularly difficult about neurosurgery, I would say, is that there's a lot of death. For me, I find that to be a difficult thing. It's not as much of it doesn't have the same frequency. It's sort of not in your face at the same with the same sort of degree of trauma as an attending as it is as a resident. But during residency, you are confronted with a lot of people dying, and you are in a situation where you generally don't know the family. You don't have a relationship with them, and you're then counseling them or delivering very bad news. It's really hard. It's really hard, and you're being asked to make decisions that are, life ending, and that's extremely difficult to bear the responsibility of. As an attending, you really are the person to whom that onus falls. And so the resident will say to you, well, this patient's exam is this, and this is what the scan looks like, and I don't think we should do anything, or I think we should do something, but ultimately it's your call. And a lot of times the families will have a lot of difficulty kind of reconciling, what's going on with what you're recommending that they do. And that can be very difficult, like when it's clear that there's nothing that can be done, and they can't, they don't quite believe it, and you're in this, your job is to explain why that's the case and why they need to let go. That's the worst part of the job. And it's really hard, and it happens more than you would think, or maybe not more than you would think, but it's like a routine part of the job for almost everybody at some point. It depends on what you do after you finish your training, but certainly during the training period, everyone kind of has that. So that's one of the things that's very difficult about neurosurgery. And I guess that just speaks to the same issue of terminal disease. If you're just coming to see a neurosurgeon, particularly if it's an intracranial process, things are frequently not going that great for you. It's wonderful when the patients do well. They're totally home runs, but that's not all the time. And you don't think so much about all the successes, of course. You think about the times that things didn't go well, and it's hard. You think about patients. As an attending, you get really attached to patients because you interact with them a lot more and you see them in your office. So it becomes a different thing. It's like the responsibility feels a bit different because you actually convince them to have surgery. You talked them through the surgery, you saw them after the surgery, you've been following them for some period of time, you're the one that has to tell them their cancer came back or whatever. So that's a whole different thing that you don't really experience as a resident, but you definitely do as an attending, and it's it is hard. I mean, it's gratifying to be on that journey with somebody, and to help them in some way, but it's also not easy. And then I guess I would just say the last thing that's difficult is, and I can just only speak for myself, neurosurgery is a very male-dominated field, and as a female, I think it's isolating for everybody, the experience of going through neurosurgery training, but as a woman, as the only woman in my program for almost the entire duration of my 7 years, and that's there were no women attendings. There was one female resident in my very first year, and that was the only time that there was another woman. And so it was pretty isolating. I think that's gotten better. Most places, not everywhere, but most places have a little bit more representation, and so that I think helps. And I don't think it's just specific to women. I mean, I guess I should say it's very dominated by white men. So I feel like it's difficult to just not be to be in neurosurgery and not be a white man. You can be a little bit more isolating than the experience if you blend in. And then you guys asked me about sort of I think so. The most rewarding part of the job is definitely like, I mean, this is true for medicine in general, is like when you make the human connection with the patients. I think that's always the most rewarding thing. Sometimes it's with the family, not always with the patient themselves, but it's what makes the job really fulfilling for physicians. And I think what most of us really thrive on at the end of the day. Also, for neurosurgery, when you really save somebody's life, it is great. I mean, there's nothing greater, really. It's like the best. You're like, wow, I did that. That's so cool. And now you can like talk to me again. That's amazing. And not every specialty gets to do that. So that's a real perk of neurosurgery, that sometimes we, like when we help people, we really help them. And yeah, I mean, like, it's just great. I don't know what else I could say about that. Self-explanatory. Memorable patients. Yeah, I mean, I've had a few for sure that are, you know, but it's like, it's just one of those things where I think this is true for everyone. Like, you know, something about the story or about the way that they resonated with you, or something really bizarre that they did, kind of like sticks with you. I had this one guy, I think probably my most memorable patient of all time was a guy that had a big sacral tumor. And so the sacrum is like the base of your spine, basically your bum. And I arranged for him to go into Memorial to get a biopsy because I wanted it to be done with like a tracker, and we didn't have we just didn't have the materials that we needed to do it at the county hospital I was at the time. He had never left whatever, like the surrounding towns in his Long Island little like enclave ever in his whole life. And he was like 65 years old, and he was a dishwasher. He worked at like the local restaurant. It was mind-boggling to me that this guy had never been into the city, but he had never been into Manhattan, and he only lived like 25 miles away. So we arranged for him to go to Memorial, which is on the east side of Manhattan, and he didn't know how to get there. So I ended up getting him an Uber. So he shows up in my office in the morning of this biopsy, and he's like, I don't know how to get there. I was like, okay. So, I mean, there is a train, but whatever. So I get the guy an Uber. I call the Uber guy and I explain the situation. And I'm like, just take him to this door. Please drop him off and then wait for him and then bring him back. So this patient was very likable, even though he was obviously not the sharpest tool in the shed. He got into the Uber driver's car and he started telling the guy about the fact that he'd never been to Manhattan and how excited he was about this new adventure he was taking. Never mind the fact that he had cancer; it's totally irrelevant to him. It seemed like, and the Uber driver was so like also similarly charmed by him that he ended up giving him a tour of the city. And so he like, I get this like ridiculous Uber bill at the end of this whole thing. The hospital did reimburse me, but I was like, but the guy comes back. He tells me how like he's had this magnificent tour. They went downtown, all the way down to the waterfront, to like, you know, to the piers. And he got to see, they drove up and down Fifth Avenue. I mean, this is all obviously way pre-COVID. And then he saw the Empire State Building, which is, by the way, nowhere near Memorial Sloan Kettering. And he decided, so then they took him he gets dropped off at the office, and he gets to the office and he tells the surgeon. Then, I mean, I've had a whole bunch of conversations with this guy, the surgeon, at this point about this patient, and, you know, because he's kind of like doing me a charity favor to take care of it. And so the guy shows up and he's like, I've never been to Manhattan. I'm so excited. And so the surgeon actually then took him out and took him on a little walk because they happened to be, his office, I guess, was actually kind of like near the plaza. So they like walked around that area of the park a little bit, and he kind of like explained where they were. It's where like FAO Schwartz used to be, that kind of area. And anyway, so then the guy finally comes back, and he is so delighted. I mean, it doesn't matter that he had like a biopsy. He's so excited about his adventures in Manhattan. And it was like one of those things where it was like, I mean, if this guy dies of cancer, at least he finally got to see New York City. And it was so great. But so not medical. So, I mean, I don't know what to tell you. Sometimes those are the things that really stick with you. And you're just like, I did something good today. It wasn't surgery, but it was still good. And, you know, I don't know. So, but that's one of the things that's rewarding about medicine, is that there is all of this other stuff. It's not just, you know, it's not just about doing the one thing, like taking care of the brain or the heart or whatever. It's all the other stuff is great too. I think my battery's about to die. Let me just hold on 1 second while I plug in my computer. I'm really sorry, I forgot to do it.
Oh, I guess her computer died.
I think she'll just rejoin us.
Yeah.
Yeah.
Also, I wanted to say, I think it's Mahi. I don't know if I'm pronouncing her name right, but that's a really good question. And we'll make sure we ask her that. Really like that. I'm gonna change my background because this, I don't know. Okay, I think that's better, right? Is that better or?
Yeah.
No, I like this one.
Yeah.
I've never been a
So,
assistant.
she'll be joining us back in a moment.
Mm.
Yeah. What do you guys think so far? I was like a little bit scared when she said that to have the perfect score to get into good medical school. I was like, what? Wait a minute. Listen, it's not that easy.
Oh no. Yeah, she scared us a little bit.
I like
It's
how
a little bit
honest she is.
Yeah.
I
Yeah.
feel
Oh,
like
she's
she's like,
back
yeah.
on her iPhone.
Yeah. I don't know if you guys could hear it, but there were like dogs in the background.
Oh, so cute. Hi, Dr. Fontana. Can you hear us?
Now, there. Sorry about that.
No worries.
Yeah, I did something to my Wi-Fi here when I was trying to plug in the phone. Anyway, mentorship. So you definitely need a good mentor for neurosurgery in general. If you're applying to neurosurgery, it's like one of the most I don't know, important things to have as a good mentor. Not just to like help you go through the process of deciding to do neurosurgery and preparing your sort of application process, but also to make phone calls for you and stuff like that. It's a very
small community, and everybody knows everybody else. And so it's not a trivial thing to get kind of like into the system without a mentor. You do need a good mentor. So I think when you're applying to medical school, it's not necessarily something you need to think about. But once you get to medical school, I think once you make the decision that maybe this is something you're interested in doing, if whatever it is really, but certainly for, I think, all of the competitive specialties, it's really important to pick a mentor that is actually in your field of interest. Oh, good. My thing is finally working again. I'm going to try and launch it from my computer. So yeah, the mentorship thing is a big thing for, here we go.
There I got it.
Yeah. Better. Okay, I'm gonna turn you off.
Actually, Dr. We have a question, but it's about the connection that you build with your patients. So you can finish talking about the mentor, and then we can ask the question if you want, or.
Oh, go ahead. Ask it now. That's it. That's all I had to say about mentorship. It's important. Pick a good one.
Yeah, Mahi asked, how do you balance forming a connection to the patient but staying somewhat distanced from your patients as a way of protecting yourself emotionally?
It's a great question that I don't know the answer to. I mean, I think the real answer is that physicians lose empathy over time as a result of the process, and it becomes actually more of an effort to make the connection than it does to disconnect, because you just get so accustomed to seeing patients as patients, if that makes sense, as something different from you. That said, I don't think it ever becomes easy or simple or straightforward to deliver bad news. It just isn't, because you're always faced with somebody who's grieving or is reacting to whatever you're saying, and that as long as you're human, you're gonna have an emotional response to that. But the act of actually caring for the patient, I think, becomes a little bit rote over time, and it does become something that you do and not necessarily something that you think of as, I'm taking care of this person's mother, or I'm taking care of this person's child. It becomes very hard when you particularly identify with a patient sometimes. Like, for example, I find it very difficult to care for children now that I have my own, but I didn't find that so difficult in quite the same way. I mean, there's no easy way to take care of sick kids, but I didn't quite like rip my heart to shreds the way it does now, because I just couldn't picture that person as my own child. But now there's like a face that I have in my head that I see in that person, that patient, and that becomes very difficult sometimes. And I think that can be true for, if somebody reminds you of a spouse or a parent or a friend, then it becomes hard to care for that person. So there's not an answer to that. Sometimes it's really hard. Sometimes it's not. It gets easier over time for kind of the wrong reasons, But it's a struggle. It's a struggle for physicians, I think. It's a struggle for the profession, is how do you maintain empathy when you're constantly being forced to deal with terrible things and terrible loss. And I think about, for example, the trauma patients. They are the trauma physicians. They are often really dealing with very gruesome things, and it's really kind of jarring to see that kind of stuff on a with any kind of frequency. It does, I think, kind of mess with you. And, you know, I mean, I had a patient, the first patient I've ever had, died on the table this past year. And it was like the most horrible thing. It was horrible. It was absolutely horrible. And like, you know, those kind of things like just kind of like haunt you. Deaths, some of them haunt you. And I think that's just part of it, part of the job. So, let's see here, onto a more uplifting topic. Do I work with physician assistants? Yes, I do. I work with residents and physician assistants and nurse practitioners. It's great sometimes, it's not so great other times. You know, they do a lot of the kind of like scut work. And every hospital has a different dynamic for how they use all the staff. That's I mean, I'm not sure it's relevant to you guys as college students, but you know, when you're applying to residencies, it is like something to think about. How much sleep I get a night, I don't know the answer to that. It's disrupted most of the time. I'm pretty good at just falling straight back asleep. So I have no idea. But do I think, I don't know it's a good question to ask what healthcare is going to look like in 10 years. My guess is it'll probably look pretty similar to the way it does now in a lot of ways. There may be some larger, you know, it may be that there are sort of fewer small hospitals and that they've been subsumed by larger corporation type organizations, such as Northwell or Partners or these, you know, Kaiser, these various kind of bigger conglomerates. But I do think that the practice of medicine will be probably fairly similar. The revenue end of things, or kind of like the mercenary aspect of medicine, I feel like has been pushed a little bit to the limit, and there's not like a lot more room to go. So I'm not sure that there's a lot more like money to be squeezed from the medicine tree, so to speak, from these businesses. I think like people are working as hard as they can for the most part and being as productive as they can within reason. And you see every once in a while that like some place will kind of cross the line and they're running too many rooms or they're committing Medicaid fraud or whatever. I mean, that's kind of like, that's like the only way really that the system can kind of get pushed beyond that or squeezed beyond what it's already doing. So I don't know. I don't really see it being all that different. You know, maybe there'll be more remote work, but I kind of doubt it. I mean, we've moved away from it already in the last couple months. We were all seeing patients Zooming initially, but now people are back in the offices and most people prefer to be in the office. So both the patients and the physicians, I think. So it's from that standpoint, I don't think that the culture of medicine is going to change very much in the way some of these other fields might, you know, like banking, for example, might be very different in 10 years in terms of where you actually have to be physically. But I don't think medicine will be. I also think like so much of medicine is about the human connection and like deciding, even something as simple as deciding who's going to operate on you is, you know, very much about how you interact with the person. And so, I don't know, you just don't get that on Zoom. So, maybe there'll be more automated stuff than there is now. For example, like radiology, dermatology, so pathology, some of that stuff is moving towards kind of like AI type of processing, so that there's fewer jobs for actual humans and more of it can be done by technology. But that's not going to be the case for surgery in 10 years, I don't think. So I just don't see that. I hope there's no more COVID in 10 years. The coronavirus has impacted my career only in that I was deployed into an ICU for 6 weeks, and that was pretty terrible. I was working mostly nights, and we had a lot of patients dying every night. We weren't operating. We weren't allowed to operate. All elective cases were canceled for, over a month in New York City. So there were emergency cases running. I guess I maybe operated once during that entire time. I covered a call night, but there was very little neurosurgery going on, probably less neurosurgery than needed to be going on, because there was probably a lot of stuff that wasn't getting treated. But other than that, experience, it hasn't really affected me. The hospital has been very much back to normal for the last few weeks, maybe even last month, I would say. And the hospital feels like one of the most normal places in New York right now, and also one of the safest places to be. So I don't know what's going to happen if we have another wave. But I don't know what you guys are able to do in terms of getting into the hospital and getting interpersonal experiences with the whole pandemic. It's probably impossible to do because the restrictions are so intense. And for that reason, you're a little bit limited. I mean, I don't think that's going to matter so much if you're a first or second year college student, but I guess if you're a junior or senior, it might matter to you, particularly perhaps for the juniors. I don't have a great solution. I mean, I think there's clinical research that can be done remotely and you can participate in, and you can seek out people who are doing that kind of stuff. You can also, you can reach out to kind of like public health type people instead of physicians and see if there's kind of stuff that you can get into that way. But it's for sure a problem, because I do think you get a lot out of that dynamic of being in the hospital and deciding if you like being in a hospital or not. And I think you need that personally before you go commit yourself to, $200,000 medical school tuition personally. But that's just me. I don't know. I would probably take time off if it were me. And I was in a situation where I needed to decide and I hadn't had the exposure I felt I needed. Because I think pretty quickly, but you do need to have it. All the COVID patients I interacted with had just pretty straightforward COVID. I didn't see any neuro patients. They were all sent over to a different hospital. So I haven't really interacted with or witnessed a whole lot of the neurologic complications other than the kind of like delirium, dementia, whatever it is that they're getting, encephalitis. But it was always masked by all this other stuff. And because I was in the ICU, I wasn't seeing the patients after they came out of the ICU. So I have had almost no interaction with it. Certainly as a surgeon now, we aren't seeing those patients. They're being seen by the neurologists, or a lot of them are in some kind of like facility. I just operated the other day with an ENT who did a lot of trachs. tracheostomies for some of the patients that have been on ventilators, and she is seeing them because she has to manage their tracheostomies, which they're now either weaning off of or needing. And she said it's been interesting to see these patients coming back, but she did say that quite a few of them had just died since she had operated on them. So anyway, I can show you a case if you'd like to see a case before we go. Do I perform robotic surgery? No, I do not. Well, I guess that's not totally true. I have. We have this cool robot called the ROSA, but it's like, I mean, it's not robot the way I think of, like, or that way like you guys probably think of robots. It basically is like a stereotactic arm that just is particularly precise in calculating where it needs to go to put in either a probe or to do a biopsy. So it's like you give it a whole bunch of, it basically registers the facial landmarks of a patient the same way all of our other stereotaxy does, but it calculates it to a much finer precision. And then because it's a robot and not a person, it's more accurate in its like placement of everything. And so that's my only robot. It's a very expensive robot, but it's not like a particularly sexy one. Yeah, that's all I got for you there. Let's see if I can get you this. Oh, I'm the host now. Okay, I've never shared a screen before, just for the record. So like, we'll just see how this works. Okay. Wow. Okay, let me start from the top. Good, can you see? I can't hear anybody. I'm gonna unmute.
Yeah, we can see it.
Okay. All right, cool. All right, so here's the story. It's a 37-year-old woman. She doesn't have any past medical history, totally healthy. She's actually an elementary school teacher. She comes into the emergency room and she's got a really bad headache. She's been dizzy. She's been getting these headaches for an entire year. And she's got 2 little kids. She's like, oh my God, I'm just so tired all the time, but they've just been getting really worse. And then because she got dizzy, she decided maybe there's something else going on that I should get checked out. So that was why she came to the emergency room. She was actually having trouble walking straight. She got an MRI. Well, she got a CAT scan first, and then she got an MRI. But just so you know, she had essentially a completely normal exam. These is like a whole lot of med speak. But anyway, her vital signs are normal. She's awake, she's oriented ×3, which means she knows her name, place, date. She's fluently speaking. All of her cranial nerves are intact. She's full strength in all of her extremities. Her sensation is normal. Her, what we do is various sort of like cerebellar signs to see, like, how fast you can alternate your fingers. Can you touch your finger to your nose and to somebody else's finger? All that stuff is actually normal. But she does have this tumor. So she gets this image. This is her eyeball. Can you see my mouse or no? Yes, you can. Oh, wow, this is so cool. So there's her eyeball. This is the back of her head. Here you can see these are her eyes, her nose, back of her head. So this is the cerebrum and this is the cerebellum. Right and left are reversed. So this is the right side. You see this cystic lesion here. And this is a contrast scan. She's got a bright sort of area of enhancement right there. So this is a very, very classic finding for a hemangioblastoma, is it has this like little nodule and then this large cyst around it. And you can see here, this is the 4th ventricle here, and this actually it's like being squished. So normally you have like a nice little round space there. Hers is not nice and round. So she's actually got a fair amount of mass effect from this lesion, but it's probably been growing relatively slowly, which is probably why she is otherwise totally normal. So with hemangioblastomas, we worry about a lot of associated, so there's a syndrome called von Hippel-Lindau, which is associated with hemangioblastomas. And so it's also associated with a variety of other lesions. And for that reason, anytime a patient comes in with a hemangioblastoma, they have to get this like really extensive workup. So she gets evaluated for, she has to get a CT chest, abdomen, and pelvis. We're looking for renal cell cancers, pancreatic lesions, pheochromocytomas. It's like a whole bunch of, and then she also has to get a whole bunch of labs to look for pheochromocytoma. We always image the entire spine because often they will have multiple hemangioblastomas, not just one. And then finally, when we treat hemangioblastomas, sometimes we can embolize them via like an angiogram. We go up with a catheter and you can get the blood supply to the lesion. And when you can do that, then the lesion is no longer a bloody lesion. So that is a great thing. This particular tumor didn't have a very big nodule, so it was not really that big a deal, but sometimes the nodule can be quite large, and it can be a real concern in terms of being able to manage the tumor. So this is actually more often the case with the spine tumors than it is with the brain ones, but at any rate, she did get an angiogram. It did not get embolized. So this is her diagnosis, and then the only other treatment option we really have for her is steroids, which was just to manage the edema associated with the tumor itself. And then what we did, sorry, all I have is the post-op imaging here, but what we did is so she was turned on to her side. We drilled away the bone here, right behind the ear. And we open up the dura, and then we used actually an ultrasound machine to identify the cyst and also the nodule. So we had our stereotaxy, which gives us like pretty good guidance and helps us to find the tumor. But then we also use the ultrasound to identify it as well and make sure that we got the nodule. And then you just pretty much just scoop the whole thing out, and that's it. That's what the fourth ventricle is coming back to normal. This is still fairly swollen, but it should, eventually look like a nice little kind of like C trapezoid, really. And that's that. So neurosurgery is very cool. Brain surgery. Okay, stop share. All right. Does anybody have any other questions that I can answer about anything? Yes, no?
I have a question.
Yeah.
So this one looked like a more straightforward like extraction of the tumor, but so like this one, it seemed like it was like a more straightforward one for you guys to like extract the tumor, because like, can you not hear me very well, or?
No, oh no, it's just my children just came in.
Oh, okay.
Sorry, I heard it like, mommy, and I was like, okay, sure, I didn't tell you. Sorry, go ahead. So say it one more time.
Yeah, so like for this case that you just showed us, it seemed like it was a more like straightforward extraction for you guys. Like the margins seemed like they were pretty defined, so you're able to like take it out, like the whole thing. But like what goes into like the determination of the margins when like the tumor is like encroaching different parts of the brain that you guys don't want to really mess with because of like the effects that will come of it? Like basically, how do you guys determine how aggressive you're going to be when taking out more difficult tumors?
Yeah, that's a great question. There's two considerations. One is, what's the pathology? So if it's a benign tumor like a meningioma, then we're going to be less enthusiastic about being aggressive. If there's a risk, then if it's a GBM or something, and there's a concern that we're trying to balance in terms of resection versus leaving stuff behind. So that's the one question. At first is the is sort of the actual pathology. And then, you know, the other question is just how much of a, like, what is it that is going to be the deficit, and how much of a risk is it really that we're talking about? So, you know, for example, when we do acoustic neuromas, there's always a risk that you're going to injure the facial nerve. But once you've committed to doing surgery, that risk is there. It's just there, and you're still going to try and get the tumor out, and you're just going to monitor. But you know, it's not typically a situation in that case where you can kind of like just leave a little and it's like hanging off the facial nerve. It's usually like the facial nerve gets stretched somehow or it doesn't, and you're either going to have a unfortunate complication in which the patient may have some degree of palsy or not, and they shouldn't, hopefully, but that's just like a known risk of that surgery. I have a patient that we're operating on Tuesday who has like a skull-based meningioma that is encasing the carotid artery on the left side. That is a case where we're going to send the patient to have the tumor angiogrammed, and if there's something we can embolize, we'll embolize, and that may make the tumor softer, but it's a little easier to dissect some of the structures around. But if it's a really stuck tumor, which meningiomas often are, then we're for sure going to have to leave some residual in that case around the carotid and probably also around the cavernous sinus. So you always know going in what your goal of surgery is and how aggressive you want to be beforehand. And then it's kind of tempered by the actual, you know, risk benefit, what the patient's willing to take on in terms of risk and what you're willing to take on in terms of risk. And then how, you know, it practically speaking, what your like gauge of that risk is in the moment. You know, for example, with a recurrent GBM, there's often discussions about this kind of thing because it's like, it's gonna leave you can take it all out, but you're gonna give the patient you know, they're gonna be weak on the right side, and they're also have a terminal disease. And how much time are you really buying them by giving them that paresis versus, you know, giving them a month? Who knows, right? These things are sometimes they're really soft calls and not so obvious. But in like the case of something that's like, you know, this meningioma, for example, where it's like, wow, I really don't want to give this guy a massive stroke for a benign tumor. It's like a no-brainer. We'll probably leave some. So someone asked a question, sorry, and I just in this chat. Activities I did to improve my dexterity. I mean, I play piano. Playing piano is way harder than neurosurgery from like a technical standpoint. So I mean, neurosurgery is not that technically challenging compared to some of the other, like vascular surgery, for example, is much finer. I mean, neurovascular surgery for sure is a little more technically challenging, but even so, I would say like plastics and vascular, maybe even cardiac, probably are a little bit more technically challenging than neurosurgery. So I don't know, maybe I'm underselling our field, but I'm not like, there was never a moment when I was like, oh my God, this is so difficult to master this skill. The anatomy is complex, and the decision making is very complex, but the actual physical act is generally pretty straightforward. 3D models. We all learn as residents on like, you know, they have like, I don't know what you call them. They're corpses. I don't know what they like. What like frozen bodies, cadaver labs. We all have cadaver labs. Yeah. So there's like the cadaver labs that people use during training, but most of the training is on people, on the patients. I mean, you're just heavily supervised, you know, and that's how surgery works. Thank you.
Does anyone have any other questions? Feel free to just shout it out or type it in. I think we could give like a minute for people to think a little bit. And if you don't have it, then fine.
Crickets.
Yep. Oh, here you go.
How intense was the training? So intense. So intense, you wouldn't even believe it. So intense. I don't know what else to tell you. It's like it was just brutal. I mean, it's gotten better. It's more humane than it used to be. But I mean, we were just working, I mean, over 100 hours a week for 7 years. I mean, it was just horrible. And then there's like people dying all the time. It's a very, very difficult training process. Not gonna lie.
I do have a question actually. So can you hear me?
Mhm.
Yeah. Oh, okay. Yeah, my Wi-Fi, I don't know what happened, but I know you mentioned how difficult it is to stay empathetical, especially with your patients and not lose that empathy. But do you think, I know there's no like real answer to this, but do you think you would have any advices to prevent that from happening, prevent yourself from losing that empathy?
No, I mean, I think it's really a problem for the medical field to address, and I do think there is some attention being paid to the issue now, maybe more than there had been. But I mean, every like kind of like wave of new physicians, it gets a little bit better in terms of the awareness of the issue. But yeah, no, I don't think so. I mean, I think the answer is for people to have a way of like coping with kind of the stresses of the job, and that really requires a more sort of systemic change from the way medicine is practiced. And that, because I mean, I think fundamentally what happens is that physicians compartmentalize because they have to, and they kind of, that becomes then you know, a way of being. And if it's a way of being, then it just like kind of becomes hard to kind of break out of that. And you really need a way to break out of that. And that I think comes from being away from the hospital and having interactions that aren't about medicine, and you know, having a life outside of medicine, this like whole work-life balance thing. And this, I'm not saying like that one can't work an enormous amount, but I do feel like the constant grind and pressure, perhaps more the pressure than anything else, than the time, is the it just makes it very difficult, I think, for people to kind of step away. And then you get into this environment where people just shut down. And if you shut down one thing, you shut down everything. And so it's like you just shut down your feelings, and then just it becomes harder to empathize. So yeah, I don't think that's something one person can kind of do for themselves, I guess, other than try and maintain balance. But there's a lot of other factors working beyond the individual, I think, in medicine to that respect. So.
I actually have like 2 more questions. So
yeah,
could I just ask both of them and then
yeah,
like
go.
right. And so okay, cool. So the first one is just regarding the case that you said you had on Tuesday, where you said you were going to leave a little bit of tumor left over. So what are going to be like the next steps after, since you leave some tumor behind? Like, what are going to be the next steps for the patient in regards to just like dealing with the condition?
Sure. So it depends on how much we can remove. But the plan would be to, so obviously he's counseled about that ahead of time. And then we say, you know, look, we are expecting there may be some that we have to leave along, in this case, the carotid artery. We're going to follow it post-operatively. We expect this is a benign tumor. So if it regrows, then maybe we'll be able to radiate it. Or, you know, I mean, that's the plan for him. You know, you need a plan for how to manage the residual if it grows. But in his case, because it's benign, you know, a lot of times they don't regrow, but usually we just monitor if there's residual tumor. And then obviously the issue is whether or not it's a cancer or not. But in his case, it's not.
And so do you think that you guys would maybe try to be more aggressive if the tumor was metastatic instead of just benign, do you think?
Well, it'll be a different texture if it's a metastatic tumor. So it won't, so meningiomas are very like tough fibrous tumors, and metastatic tumors tend to be a good deal sort of softer. So it won't have the same, it won't be the same tumor. It won't necessarily pose the same challenge. And probably wouldn't be as adherent to the structures. But yes, to your point, like if it turned out to be a metastatic lesion, we probably would try a little harder to like skeletonize some of these structures.
And then just my last question, like given your experience, like so far, what do you think are just some defining qualities of a good surgeon?
Oh, yeah, basically ability to cope with failure. Sorry about the lighting. It's like Blair Witch. So I would say ability to cope with failure, resilience, work ethic. Those are probably the most important. I'm just trying to think. When I think of all the people I know, yeah, I mean, they're and I guess just a passion for it. You have to really love it. There's no question about that. I think most people that do it do love it, and because it is actually really fun. But yeah, you gotta love it, and then it takes a lot out of you. It's like it's a real sacrifice in a lot of other parts of your life. So you have to want it.
Oh, thank you. Appreciate that.
Yeah.
Okay, I think
That's it. I mean, anything else?
thank you so much. I'm sorry.
Huh?
No, we spent about an hour and a little bit more. Thank you so much.
Oh yeah, we're good.
for
You're
staying
okay.
with us. Yeah.
Okay.
Thank you.
Thank
That
you
was
so much for
fascinating.
Oh, you're welcome. It was fun. Good night, guys. Good luck.
Thank you.
Oh, and do you want me to give you my contact info? I guess you can email it to them.
Yeah.
Yeah.
I'll email it to
Yeah.
them, for
Yeah.
sure.
Okay. All right.
Thank you.
Yeah.
Have a
Bye,
great
bye.
week.
You too. Bye.
Bye. Okay, guys, thank you so much for coming. I think I'll end the meeting right now. Good luck with everything, guys.
Bye, guys.